Hi everyone, this is Hani, one of your ultrasound faculty, and I'm going to spend some time talking with you today about cardiac and lung ultrasound use in the ED and how ultrasound can be used to help us figure out what's going on when that acutely dyspneic patient may present to the front door of RED. So we've all been in this situation before. An unstable, hypotensive, hypoxic patient shows up, and we have no idea what's going on with them. It may feel like we're standing in the middle of the desert and that there's no one around to help. And if there's one thing I want you to take away from this lecture, it's that ultrasound is survival. And what I mean by that is that in these cases, ultrasound is one of the things that really helps us to rapidly identify what's going on with the patient in order to save a life. So in this lecture, we're going to talk about the how. We're going to start by covering the basics of the echocardiogram. Next, we'll talk about cardiac function. Following that, we'll discuss pericardial effusions and tamponade. And last, we'll talk about some of the supplemental tools that we use, such as the lung ultrasound and IVC assessment. So we'll first start and talk about the basics of the echocardiogram. This may seem pretty intuitive, but the probe that you want to use is the phased array or the cardiac probe. And the reason why is you're trying to squeeze in between the ribs, and this is the probe that has the best footprint and the smallest footprint to allow you to do that and to help you optimize your views. Next, there are 4 key views when doing any basic echocardiogram. The first 2 are the parasternal views. Those are obtained on the anterior chest wall, both the parasternal long and the parasternal short view. The next is the subxiphoid view, which is obtained in the upper abdomen, looking upwards at the heart. And the last is the apical 4-chamber view, and we'll cover each of these now. One other thing, just pay attention to where the indicator is on your screen. Here at UW, we've agreed to be in line with cardiology, so the indicator is always pointed towards the right side of the screen for any sort of cardiac exam. And I'm going to teach this lecture and center this lecture assuming that the indicator is on the right side of the screen. If you find that it's flipped on you, you may just need to change the exam type and go back into the cardiac setting. So the first view is the parasternal long view. This is typically obtained by putting the probe in about the 3rd or 4th intercostal space, just lateral to the patient's sternum. And when you're rotating through the different views, you almost want to rotate in a clockwise fashion. So the first place that the indicator should be pointing is towards the patient's right shoulder. And this is the view that I typically start with and the view that I think and consider as home base. So if I ever get lost, I always come back to this view. Here is what a normal parasternal long looks like. Let's review some anatomy. The very first thing that we're going to hit at the top part of our screen is the right ventricle. Just beneath that, we have the left ventricle here. Here's our aortic root and our aortic outflow tract. This is the left atrium, and in between the left atrium and the left ventricle, we see the mitral valve. And last is the descending aorta, which we see posterior to the left ventricle here. Next, you'll want to rotate your probe very slowly and carefully so the indicator is pointing towards the opposite shoulder, towards the patient's left shoulder, to obtain the parasternal short view. Here is what a normal parasternal short view looks like. When you're assessing any sort of cardiac function, you want to be at the level of the papillary muscles, which you see here. And just to review, this is the right ventricle and this is the left ventricle. This view is pretty good at assessing the septum and looking for signs of right heart strain, as well as things like wall motion abnormalities, which are a little bit more advanced. The next view is the apical 4-chamber view, which is my favorite view. This is obtained by placing the probe in the intramammary fold in men and women, or just beneath the nipple and slightly lateral. Your indicator will now be pointing towards the patient's left elbow. So just to recap, for the parasternal long view, the indicator is pointing towards the right shoulder, for the parasternal short view, towards the left shoulder, and now for the apical 4-chamber view, towards the left elbow. Here's what a normal apical 4-chamber will look like. To recap, this is the right ventricle, and this is the right atrium. This is the left ventricle, and this is the left atrium here. If you ever get confused about that, there's a couple of key things to help you identify the right versus the left side of the heart. The first is the tricuspid valve, which sits right here. The tricuspid valve will always sit closer to the apex of the heart, so that to me identifies this as the right side of the heart and this as the left side of the heart. The other thing is there's this fibrous band that sits in the apex of the right ventricle. You can see it very faintly here. That's actually called the moderator band, and that's only present in the right ventricle and not the left ventricle. So if you ever get confused or if you're ever not sure what you're looking at, which can happen in cases of severe pulmonary hypertension and when the right ventricle starts to get dilated, just look for those key findings to help you straighten out which side of the heart is the right and which side of the heart is the left. The last view is the subcostal view. Now this is the view that we're most familiar with as we routinely use it in the FAST exam. The indicator should be pointing towards the right side and should be in line with where the indicator is on your screen. This is the best view for obtaining information regarding a pericardial effusion and to look for evidence of tamponade. Here is a subcostal view. So this is the patient's liver, and the first thing that we hit beyond the liver is the patient's right ventricle and right atrium here. The left ventricle and the left atrium are just posterior to that. And when you're assessing for a pericardial effusion, you want to look at all the chambers of the heart. So make sure your depth is optimized to really see the back walls of the heart. And we'll review what that looks like in a little bit. So I know what you're thinking, but how do I make it look like that, right? Here are some tips and tricks that I've learned along the way and things that I think will help you to really optimize those 4 windows. First, the way to my heart is to use more gel. If you're finding that you're having to turn the gain up on your screen, you're going to actually lose some image resolution when you do that. So using more gel will actually make your image a little bit more crisp, and it'll make your life a lot easier, so don't hesitate. Next, press harder. The goal of this exam is to really try to fit your probe in the patient's intercostal spaces in between their ribs. That may be a little bit uncomfortable for the patient. I typically will press until the patient tells me that they feel uncomfortable, at which point I'll lighten up my pressure. But you'll be really impressed by how simply applying a little bit more pressure will allow your probe to fit in between those ribs a little bit easier and really help you to get a better picture. But really, you're probably still not pressing hard enough, so I really want you to practice this the next time that you do an echo and RED. Next, swirl. And what I mean by that is outlined in this video from Core Ultrasound. I'll typically start on the anterior chest wall and do these big circular movements on the anterior wall, and generally the idea or the spot that I think that the best view will be. And then from there, I kind of make these finer movements, these fine adjustments to optimize my image and get my mitral valve and my descending aorta in view. Next, positioning. Don't hesitate to have your patient go into the left lateral decubitus position or have them actually lean forward. You'll find that that'll actually pop the heart out of the thoracic cavity a little bit, bring it closer to your probe, and make the images a little bit easier to obtain. If I find that it's going to be a challenging echo, I'll actually just do this up front. But when you're doing the subxiphoid or the subcostal view, go ahead and put the patient back in the supine position. Next, if something doesn't work, try something else. Some other things that I'll try is have the patient take a deep breath in, have them exhale, and hold their breath at the end of the exhale. I'll take off the patient's leads, take them off of cardiac monitoring, and put my probe over where the leads were. But certainly one of the worst things that you can do is give up. So just practice, 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 and try not to give up. Next, if you see something in one of the views, you want to look for it in the other views. And typically when we're talking about echoes, one view is no view. You should really work to obtain at least 3 out of the 4 views in order to help you really tease out what's going on. And again, practice, practice, practice. I've actually started just ultrasounding my young healthy patients that come into the ED with chest pain, typically looking for a pericardial effusion, or which would be a sign of pericarditis, so that when the time comes, I know how to do it. So practice as much as you can. So those are the 4 basic views of the echocardiogram. We covered the parasternal long, the parasternal short, the subxiphoid, and the apical 4-chamber view. We'll change gears now and talk about cardiac function. So our job in the ED is to tease out if the function is normal, reduced, or hyperdynamic. It's not our job to tease out any valvular pathology or if the patient's ejection fraction is 45 versus 55%, but rather just a more global assessment of what the heart is doing. So this is that normal heart that we looked at a little bit earlier. A couple of things is, one, when you're assessing for function, you want to look at the actual LV walls themselves. And with every sort of beat, the LV walls should appear to be getting thicker, and the cavity of the LV should reduce in about 50 to 60%. The other place to have your eye, and we'll talk about this more in the advanced lecture, is at the anterior tip of the mitral valve, which you see here. With every sort of beat, the tip of the mitral valve should slap, it should high-five the septum, which you see pretty nicely here. But with heart failure comes valvular disease, so I wouldn't hang my hat on that. So we'll talk now about what reduced function looks like. Again, pay attention to those LV walls. You'll notice that they don't appear to get thick with every beat, and the actual cavity of the LV doesn't get smaller every time the heart beats. At a later point, we'll talk about some of the supplemental tools, the lung ultrasound and the IVC assessment, and in the more advanced lecture, we'll talk about the E-point septal separation, or the EPSS, which is a more quantitative measurement of someone's ejection fraction. This is a heart with severely reduced ejection fraction. What you're seeing here is the right ventricle, this is the left ventricle, this is our aorta, this is our left atrium, and this is our descending aorta here. What you're seeing is that the walls of the LV themselves are hardly getting thicker, and the actual cavity of the LV does not really appear to be changing in size. Again, look at the tip of the mitral valve. You'll notice here that it hardly comes near the septal wall. So this is a heart with a pretty severely reduced ejection fraction. Here's the same heart in the parasternal short view. So you'll notice that the walls of the LV and the cavity size of the LV are hardly reducing in size. And here's the same heart in the apical four-chamber view. So again, this is the right side of my heart. You notice the tricuspid valve here sits closer to the apex than the mitral valve. And you're noticing that the walls of the LV themselves don't really appear to be moving all that much. There's actually another really interesting finding here, and that's this. This is an LV thrombus. Because this patient has such severe heart failure, they've actually gone on to develop thrombi in their left ventricle. So in reduced function, we obviously want to be cautious with fluids, but we'll talk about those supplemental tools later and how to tease out if somebody is volume overloaded. And also, don't forget about diastolic dysfunction. We talk a lot about systolic function, but don't forget there's an entire category of heart failure that exists, and evaluating for diastolic dysfunction is much more advanced and something that we're not going to cover today. Next, we'll talk about what hyperdynamic states look like. So again, pay attention to those LV walls, and in these cases, the LV walls are going to be touching with every beat. They're going to appear to be kissing every time the heart enters systole. We'll also talk about the supplemental tools in a little bit and how those could also help you to guide management in these patients. Here's the parasternal long view of a patient with a hyperdynamic state. What you're seeing here is, again, the RV and the LV here, and every time the heart beats, you see the walls of the ventricles nearly kiss, nearly touch every time the heart squeezes. And you can see that outlined here. Here's the same heart, but in the parasternal short view. Again, you're seeing these two papillary muscles nearly touch, nearly kiss every time the heart squeezes, and the actual cavity itself goes to a complete near close with every beat. So in hyperdynamic states, these are patients that obviously need fluids. One other PSA is tachycardia does not always equate to a hyperdynamic state. You can have a hyperdynamic state with a normal heart rate and vice versa. Next, we'll talk about pericardial effusions. These are anechoic fluid collections that track around the heart, and they always track anterior to the descending aorta, which is why it's so important to have the descending aorta in your parasternal long views. The best views to obtain when looking for a pericardial effusion are the parasternal long and the subxiphoid or subcostal views. Here's that normal heart that we've been seeing throughout the lecture. Now our eye is going to be around this hyperechoic line that goes anterior to the RV and posterior to the LV and in front of the descending aorta here. That's the pericardium. And you'll notice that the descending aorta is not within the pericardium itself. Here's the subcostal view that we saw earlier as well. Again, this is our liver. This is the right side of our heart, and this is the left side of our heart. We want to make sure our depth is optimized so that we're seeing around the entire heart. And now we're focusing on this bright white line that circles the entire heart. That's the pericardium. Here's a case of a parasternal long view with an anechoic fluid collection, which is suggestive of a pericardial effusion. A couple of things. One, you see the effusion track anterior to the right ventricle here, posterior to the left ventricle, but then also in front of the descending aorta, which you see right here. That's the hallmark of a pericardial effusion. Next, you want to make sure that your gain is optimized. You'll notice that the black, or the blood in the heart itself, is this dark anechoic structure, right? So then that way you know that the pericardial effusion matches what the fluid in your heart looks like. So that would help you distinguish it from something like a fat pad, which we'll see in a little bit. Here's another example of a heart with a pericardial effusion. This is a subxiphoid view. Again, pay attention to where our depth is. We're almost 27 centimeters on the screen here. And what you're seeing is this posterior effusion, this anechoic collection that sits behind the left ventricle here. This is a small to moderately sized effusion. And again, one view is no view, so I would want to see this effusion on at least 2 out of the other views as well. So whenever you see an effusion, the next question you need to ask yourself is there evidence of tamponade? And there are 4 key findings when evaluating for tamponade. Those findings are 1, a pericardial effusion, 2, RV collapse in diastole, 3, RA collapse in systole, and last, a fat or non-collapsible IVC. Here's an example of a parasternal long view with evidence of tamponade. What you're seeing here is the pericardial effusion track anterior to the right ventricle, posterior to the left ventricle, and in front of the descending aorta. But what you're also seeing is this collapse of the right ventricular wall. It's kind of doing this bouncing up and down movement. We call that the trampoline sign, and really that should never happen unless something bad is going on. I always have a hard time having my eye look two places at once, so I'll use the M mode tool. I'll drop this line actually down through the right ventricular wall and through the tip of the mitral valve here, and that'll spit out an image that looks like this. So what M mode does is it's actually plotting what's going on in this line over a period of time. So the first line that you're going to see is the right ventricular wall. Next, you'll see the actual cavity of the right ventricle, then the septum, and then you'll see the cavity of the left ventricle. And this line here represents the mitral valve. So what's happening is the mitral valve is opening, the heart is filling, the heart is in diastole, and you look up to see what the right ventricular wall is doing, and you see that it's actually collapsing here with every beat. That is a hallmark of tamponade, and this M mode tool really helps you to tease out exactly what's going on. And also, don't forget to look at the IVC. In this case, we see a fat IVC, which is hardly changing with respiratory variation. So, size does not equal tamponade, and know that even very small effusions can wreak havoc. We're going to play a little game now called tamponade or not. I'm going to show you a series of echoes, give you a little pause, and then tell you what I think. Here's case number 1. Do you see any evidence of tamponade? No, I don't either. Again, this is a parasternal long view. What we're seeing here is the presence of a pericardial effusion. But again, I'm not seeing the right ventricular wall collapse. Again, I would want to see this in some of the other views as well, just to confirm that it's not truly, that there is no evidence of right atrial collapse. Here is a subxiphoid view. Do you see any evidence of tamponade? Yeah, this is a heart that I would be worried about. You're seeing this anechoic collection anterior to the right ventricular wall, and not only are you seeing this right ventricle do this weird bouncing movement, that trampoline movement that we saw earlier, but you're also seeing the wall of the right atrium here start to collapse in as well with every beat. That is a heart that I would be concerned about for tamponade. Here's another example. Do you see any evidence of tamponade? No, this is actually the same example that we saw a little earlier. Again, we see the presence of this posterior effusion, and I would want to see it in some of the other views, but based on this alone, I'm not concerned about tamponade. Here's another example. Do you see any evidence of tamponade? Yeah, this is a heart that I'm worried about. Again, look at the right ventricular wall up here, and you see it's kind of doing this abnormal paradoxical bouncing movement, which is very concerning for tamponade. Here's another example of a subxiphoid view. Do you see any evidence of tamponade? It's a little hard to tell. I would probably say that there's tamponade here. Again, I would want to see this heart in some of the other views, but you see this presence of a very large pericardial effusion here, and the thing that's catching my eye is it looks like this right ventricular wall is collapsing, but again, it's a little hard to tell, and I think in this case, some of the other views may be a little bit more helpful. But if I'm concerned enough about this echo that I would say this is probably tamponade. So there are a few fake outs that you need to be aware of when assessing for pericardial effusions. The first is this. We see this anechoic collection just lateral to the descending aorta. That's not a true pericardial effusion. What that actually is pleural fluid. And again, that's why it's so important to pay attention to your descending aorta, because pleural fluid will actually track lateral to the descending aorta, whereas pericardial fluid is actually going to track anterior. I always love showing this example of a patient that I recently took care of with ESRD who presented with chest pain, because they have both a pericardial and a pleural fluid collection. What you're seeing here is this is a parasternal long view, so this is all the left ventricle here, and posterior to the left ventricle, we're seeing this effusion, and it's tracking just anterior to the descending aorta here. But you're also seeing this very large effusion here, which is all lateral to the descending aorta. So that's the pleural fluid, while this is the pericardial fluid. Here's another example. This is actually a fat pad, and the way I know that is the actual material within the fat pad itself is kind of more of this heterogeneous material. It kind of has a more speckled appearance, and it doesn't appear to match the fluid that's within the cavities of the ventricles themselves. And this is probably one of the largest fat pads that I've ever seen. The other thing that you'll notice is every time the heart beats, the actual fat pad appears to be moving with the heart, and that's because it's adhered to the ventricular walls. Here's another example. This is actually clotted blood. So this was a trauma patient, and what you're seeing is not only the presence of this effusion here, but this giant blood clot sitting right in front of the right ventricle. The other thing is that this would be concerning for tamponade. I'm seeing some collapse of the right atrium here. Again, size doesn't matter, but rather the rate of accumulation of an effusion. So again, with those pericardial effusions, watch out for those fake outs and always ask yourself, is it tamponade? Did you remember those 4 findings of tamponade? Let's review them. 1. The presence of a pericardial effusion. 2. Right ventricular collapse in diastole. 3. Right atrial collapse in systole. And last, a fat, non-collapsible IVC. We'll change gears now, and we'll talk about the supplemental tools that we use, such as the lung ultrasound and assessment of a patient's IVC. The first thing I want to talk about is lung, and there was this awesome review that came out in JAMA in 2005 asking the question, does this patient with dyspnea in the ED have heart failure? The big takeaway from this article is that our exam findings and our x-ray findings have really poor sensitivity. Really, our exam and our x-ray findings are quite trash, and ultrasound, lo and behold, is superior. This study came out in 2019, demonstrating and comparing ultrasound use to standard chest x-ray plus pro-BNP. It found that the use of lung ultrasound was 94.5% sensitive in screening patients for heart failure and could also be done in under 5 minutes, compared to 2 hours in patients who had x-rays plus BNPs done. So to do a lung ultrasound, the probe of choice is going to be the cardiac or the abdominal probe. I actually like the abdominal probe more when assessing someone's lungs because it has a wider footprint and it actually allows you to look at more than one space at a time. It also gets to the appropriate depth, and we'll talk about that in a little bit. When you're doing this exam, you should aim to look at 12 different lung zones. That's 8 anterior zones, so you could divide each side of the chest into 4 quadrants and 4 posterior zones. When you're doing this exam, you want the indicator pointed upwards towards the patient head for the entire duration of the exam. These are A lines. This is what a normal lung will look like. So what happens is the ultrasound waves will actually hit the pleural line here and then be scattered by the air in the lung itself. And what the machine is trying to do is it's trying to guess what comes next, and it copies the actual pleural line in this fashion, and they kind of are these equidistant lines that go all the way down your screen. Those are A lines and what you'll see in a normal dry lung. Contrary to that, these are B lines. What you're seeing here is the pleural line at the top of your screen and these bright white comet tails that streak all the way down your screen. To technically be considered a B line, you have to have the streak go down to at least 15 centimeters. So you really want to optimize your depth for that. So just to compare, A lines versus B lines. A lines are those artifact lines, those equidistant copying of the pleural line that you're seeing here, whereas B lines are those bright white comet tails that streak all the way down your screen. And what's going on a molecular level is in A lines, the interstitium is normal, and the air in the lung is actually scattering the ultrasound beams. This could be thought of as a dry lung, whereas in B lines, the interstitium is thickened or fluid-filled, so you can consider this to kind of be wet lungs. Here's a nice example of somebody with both A lines and B lines, and the reason why I like this is that you should know that both A lines and B lines cannot exist at the same time, and the B lines that you're seeing here on the left side of your screen are actually erasing away the A lines, what you're seeing here. But this patient also has A lines, these equidistant lines that go all the way down your screen as well. But just know that these cannot coexist. So when I'm doing this exam, I will typically try to show myself A lines because then I've proven to myself that there are no B lines. So when you're doing a lung ultrasound, you have to go into it with a clinical question in your mind. B lines themselves can be either focal or diffuse. Focal B lines are things like pneumonia, atelectasis, or pulmonary contusions, which you'll see in the setting of trauma, whereas things like diffuse B lines are going to be more cardiogenic causes or things that give you a more diffuse reaction like ARDS, acute chest, or high-altitude pulmonary edema. So just because somebody has B lines on lung ultrasound, that doesn't necessarily mean that they need to be diuresed. To have a positive lung zone, you need at least 3 B lines. And to be considered diffuse, you need to have at least 2 positive zones per side. Typically when I'm doing this exam, I'm only really looking at the anterior lung fields, And if I'm seeing beelines everywhere in at least 2 or 3 spots on each side of the lung, then I just consider that diffuse, and I don't go on to look at the posterior fields. We'll talk about pleural effusions next and how these look under ultrasound. They're actually pretty easy to do. You're going to put your probe in the right upper or the left upper quadrant, similar to the spots where you put the probe for the FAST exam, but slide upwards to see the diaphragm themselves. The indicator will be pointing towards the patient's head. This is an example of a normal lung and normal hemidiaphragm. What you're seeing here is the liver. This hyperechoic line anterior to the liver is actually the diaphragm, and then these hyperechoic bodies here with these shadows behind them, those are your spine. And obviously the spine does not end in the thoracic cavity. What's happening here is the ultrasound waves are hitting the air in the lung, and they're hiding the spine on the opposite side of the diaphragm, indicating that there is no pleural effusion in this example. Here's a case contrary to that, where you're seeing the spine on the opposite side of the diaphragm and this anechoic collection just above it. This is actually a pleural effusion, and we call this the spine sign because what's happening is the ultrasound waves love going through the fluid of the lung here, and they now give you a reflection of the spine on the opposite side of the diaphragm. I always tell our learners to also scan upwards and look at the lung parenchyma itself. So this is a case of pneumonia, and what you're actually seeing here is a few key findings. First, you're seeing a spine sign, a reflection of the spine on the opposite side of the diaphragm. Next, you're seeing these air bronchograms, which are these hyperechoic lines that are kind of diffuse throughout the lung parenchyma itself. Next, you're seeing hepatization, so the lung itself starts to look like the same texture of the liver. And this wouldn't be a lecture in 2020 if we didn't at least spend some time talking about COVID-19. COVID has brought a lot of attention to lung ultrasound and whether or not we can be using lung ultrasound in the screening of these patients. Some key findings of COVID infection on lung ultrasound include an irregular pleural line. So we call that the shred sign. In a normal lung, the pleural line should look smooth. But as you see here, this pleural line has this irregular shape to it. It kind of looks a little beat up, and that is indicative of a viral infection. Next is you'll see these patchy beelines, kind of one beeline here, and less confluent like we saw in the examples of heart failure a little bit earlier. Last is you're going to see these small consolidations just beneath the pleural lines. We call that subpleural consolidations. There was one right there, and that is another hallmark of COVID-19 infection. So that is lung ultrasound. Just remember, correlate clinically, and you should start to use it because it's actually pretty cool. We'll change gears now and we'll talk about the IVC. This is actually pretty easy to obtain. You want to place your probe in the subxiphoid space with the indicator up towards the head, and you got to press hard because you're trying to get some of the bowel gas out of the way. The other thing that I like to do is hyper angle upwards because I want to see the IVC itself dumping into the right atrium. And then last, you want to fan from side to side, identifying both the IVC and the aorta because you don't want to confuse the two for each other. The spot where you want your eye to be is about 2 centimeters from where the IVC enters into the right atrium, so right around here, or about 1 centimeter from where the hepatic veins dump into the IVC, so somewhere around here. The IVC has a bit of controversy surrounding it, a bit of drama, if you will. It originally arose, and we thought it would be a good marker for how to guide our fluid resuscitation in many categories of patients, but instead now what we're finding is the IVC itself and the IVC collapsibility may or may not actually dictate if a patient is responsive to fluids. Next is don't confuse the aorta for the IVC. So the two structures sit right next to each other in the body, and the IVC also changes with respiratory variation. So looking at pulsatility alone is not sufficient. That's why I hyperangulate upwards, because I want to see the IVC going directly into the right atrium, and I try to visualize both so that I know I'm not confusing one for the other. Here's a good technique that I try to practice and teach. So again, I hyperangulate upwards, looking at the IVC dumping right into the right atrium, which you see here, and then I'll actually fan away from the IVC, away from the patient's liver, to identify the aorta. The aorta actually tracks posterior to the heart, whereas the IVC dumps right into the right atrium. So once I've identified these two structures, then I know how to make my judgment based on the IVC and not the aorta. Visualize both so you don't confuse one for the other. When we talk about IVC, we should think about it as fat or minimal change with respiration versus flat, highly collapsible with respiration. I think IVC still has good utility in the assessment of these patients, but what to do with an IVC that's moderately collapsible, I'm still not totally quite sure. So things that'll give you a fat IVC are things like pulmonary embolisms, heart failure, and tamponade, like we talked about earlier. Things that'll give you a flat IVC are things like sepsis or hypovolemia from hemorrhage, for example. Here's an example of a flat IVC. So again, I want my eye about 2 centimeters from where the IVC enters the right atrium, so somewhere around here. And what I'm seeing here is with every sort of inspiration or every sort of breath, I'm seeing the walls of the IVC come to a near complete close. That is a flat IVC. Contrary to that, this is a fat IVC. So again, here's my hepatic veins dumping into my IVC here, and I want my eye about 1 centimeter away from that. And what I'm seeing here is that with respiratory variation, this has very minimal respiratory variation. The vessel itself does not appear to be collapsing with any sort of respiration. So that is the IVC. Remember to ask yourself, is it fat or is it flat? And know that there's a lot of drama surrounding the IVC, but that it may still have some clinical utility. So that's basically it. We talked about the how, the 4 basic views of the echocardiogram. We talked about cardiac function and how our job in the ED is again to tease out if the function is normal, reduced, or hyperdynamic. We talked about pericardial effusions and tamponade. Do you remember those 4 key findings? 1, presence of a pericardial effusion. 2, right ventricular collapse in diastole. 3, right atrial collapse in systole. And 4, a fat, non-collapsible IVC. And last, we talked about the supplemental tools that we use, the lung ultrasound and assessment of a patient's IVC. Coming up in the advanced lecture, we're going to talk about the E-point septal separation, or the EPSS, which is a more quantitative measurement of a patient's left ventricular function. We'll also talk about the right heart and why the right heart matters and how to assess for right heart dilation. And last, we'll talk about ultrasound use in the setting of cardiac arrest.